Chronic hypertension. During pregnancy, chronic hypertension is defined as hypertension diagnosed before pregnancy or hypertension diagnosed before 20 weeks of gestation or hypertension that persists after 12 weeks postpartum. So the diagnosis may be difficult to establish in women with undiagnosed chronic hypertension that comes late for perinatal visit in the second trimester of pregnancy. This is because of the physiologic effect of the pregnancy on blood pressure that is expected to decrease, so that makes difficulty in the diagnosis of hypertension in this woman. It affects 1 to 5% of all pregnancy. Currently, the incidence of chronic hypertension in pregnancy is said to be increased because of the increased maternal age at the time of pregnancy and increased prevalence of obesity. So, based on the etiology, chronic hypertension is classified into the primary or essential hypertension and the secondary hypertension. The primary hypertension is the most common form of chronic hypertension diagnosed during pregnancy. It accounts around 90% of the cases. The exact etiology of the the primary or essential hypertension remains unknown, but there are several risk factors that predispose for the development of primary hypertension. This includes advanced age, obesity, family history. If the woman had family history, one of the family is affected, it has twofold increased risk of having hypertension. The black race, hypertension is more common, more severe, and high chance of causing organ damage in black race compared with the white. High sodium diet, physical inactivity, cigarette smoking increase the risk of developing primary or essential hypertension. Secondary hypertension, it accounts around 10% of the cases of the chronic hypertension. It is the chronic hypertension secondary to one of the following underlying disorders such as renal disease like glomerulonephritis, interstitial nephritis, polycystic kidney disease, renal artery stenosis, collagen vascular disease, endocrine disorders like diabetes with vascular involvement, pheochromocytoma, hyperaldosteronism, and hypothyroidism, hyperthyroidism, hyperparathyroidism can also cause the secondary hypertension. Coarctation of the aorta is also the other cause of the secondary hypertension. Chronic hypertension can also be divided into two based on the extent of systolic and diastolic blood pressure at the time of measurement. We can classify as mild chronic hypertension and severe chronic hypertension. So when we say severe chronic hypertension, systolic blood pressure greater than or equal 160 mm of mercury, or diastolic blood pressure greater than 110 mm of mercury. So for the management and counseling purpose, chronic hypertension in pregnancy also categorized into two. So the low risk chronic hypertension and high risk chronic hypertension. The BP criteria is based on the initial measurement irrespective of the antihypertensive treatment. We categorized a woman into the low risk chronic hypertension if it is the mild essential hypertension or uncomplicated essential hypertension. That means essential hypertension with no end organ damage. If there is no previous perinatal loss, we classify it as low risk chronic hypertension. So that in this category, the overall perinatal outcome is said to be similar to that of the general obstetrics population. The high risk chronic hypertension is in the presence of all form of secondary hypertension is categorized as high risk. The severe chronic hypertension, if there is a target organ damage, like if there is a left ventricular dysfunctions, if there is hypertensive retinopathy, hypertensive nephropathy, stroke, can be categorized as high risk. If the previous perinatal loss, we can also categorize as high risk. A woman who was diagnosed to have a low risk chronic hypertension early in pregnancy may progress to have high risk chronic hypertension if she develops severe hypertension or preeclampsia. So the maternal and perinatal risks associated with the chronic hypertension. So pregnancies complicated by chronic hypertension have an increased risk of superimposed preeclampsia, placental abruption, preterm birth, increased risk of cesarean section. There are also maternal complications like pulmonary edema, cerebrovascular accident, congestive heart failure, and the others will also increase. So let us start from the superimposed preeclampsia. A woman with chronic hypertension have an increased risk of having superimposed preeclampsia. In general, the incidence is said to be 20 to 50%. So the diagnosis of superimposed preeclampsia is made if in the presence of any one of the following, any one of the two. Like if there is a development of a new-onset proteinuria defined as 24-hour urine protein greater than or equals 300 milligram, or spot urinary protein to creatinine ratio greater than or equal 0.3 in a woman with hypertension, no proteinuria before 20 weeks of gestation. So the other thing is severe exacerbation of hypertension plus the development of symptoms of preeclampsia or thrombocytopenia or abnormal liver enzyme in a woman having hypertension and proteinuria before 20 weeks of gestation. With this development, we can say that there is exacerbation of, the development of superimposed preeclampsia. So the superimposed preeclampsia is difficult, maybe impossible to differentiate from the severe form of chronic hypertension, especially if the woman presents later in pregnancy, especially after 20 weeks of gestation. But there are some features that suggest the development of preeclampsia, like the presence of hemolysis, thrombocytopenia, the elevated liver enzyme hemoconcentrations are in favor of the development of preeclampsia. For management purpose, superimposed preeclampsia is classified into two, that is superimposed preeclampsia and the superimposed preeclampsia with severe features. So we do have a criteria to say superimposed preeclampsia, like if the woman had sudden increase in blood pressure that is previously well controlled, or elevation of blood pressure that needs escalation of antihypertensive medications to control the blood pressure, that's one criteria, or a new onset of proteinuria or sudden and sustained increase in proteinuria in women with known to have proteinuria before conceptions or early in pregnancy. So if the woman fulfill one of the two, we classify it as superimposed preeclampsia without severe features. So superimposed preeclampsia with severe features, the diagnosis is made based on the presence of any of the following 5 criteria, like severe hypertension despite escalation of antihypertensive medication is one criteria. The second is persistent cerebral or visual symptoms. The other is the sign of significant increase in liver enzyme like epigastric or right upper quadrant pain, or elevation of liver enzyme like SCQT, CQPT 2 times the upper limit of normal. If there is thrombocytopenia like less than 100,000 per microliter is another criteria. New onset and or worsening of the renal insufficiency is said to be the other criteria for the diagnosis of superimposed preeclampsia with severe features. So most of the superimposed preeclampsia with severe features, in contrary to the preeclampsia in the absence of chronic hypertension, diagnosed before 34 weeks of gestation. In one study, it says around 44% develop after 34 weeks of gestation. So it is also the incidence of this superimposed preeclampsia is vary in those having mild chronic hypertension and severe chronic hypertension, as you see in this figure. And the studies show that the rate of superimposed preeclampsia is not affected by maternal age, race, and the diagnosis of proteinuria early in pregnancy. But there are factors that increase the risk of superimposed preeclampsia, like a woman having chronic hypertension for greater than or equal 4 years, and those with preeclampsia in the previous pregnancy, and those with diastolic blood pressure greater than or equal 100 have high risk of developing superimposed preeclampsia. So there is an increased risk of preterm birth, placental abruption, and fetal growth restriction in a woman having chronic hypertension with the development of the superimposed preeclampsia. So administration of low dose aspirin is very important to reduce the risk of superimposed preeclampsia that we are going to discuss it later. Placental abruption, the other complications, it occurs in 0.7 to 2.7% of a woman with mild chronic hypertension, 5 to 10% of a woman with severe or high-risk chronic hypertension. With the development of superimposed preeclampsia, the risk of abruption is significantly higher. And also, the use of antihypertensive medications to control the blood pressure, it doesn't reduce the risk of placental abruption. The other complication is fetal growth restriction. It occurs in 10 to 20% of the women with chronic hypertension. So it is one of the signs of placental dysfunction, and with the development of superimposition, the risk of fetal growth restriction as high as 15%, 5-0. Preterm births, the overall incidence of preterm births in a woman with chronic hypertension is 12 to 34%, but the risk it reaches 62 to 70% in the presence of superimposed preeclampsia. So this preterm birth is responsible for the increased risk of perinatal mortalities in pregnancies complicated by chronic hypertension. It is 3 to 4 times higher compared with the general obstetrics population. So there is also high rate of preterm induction of labor for maternal or fetal indications. So as a result, there is an increased rate of cesarean section. So as we discussed before, the maternal complications like pulmonary edema, hypertensive encephalopathy, like this hypertensive encephalopathy is commonly occurred in a woman with severe uncontrolled hypertension, systolic blood pressure greater than 220 or diastolic blood pressure greater than 130 millimeters of mercury. Retinopathy is there, cerebral hemorrhage, acute renal failure, significantly higher. So let us see the management. The primary objective in the management of a pregnancy complicated by chronic hypertension is to reduce maternal risk and to achieve optimum perinatal survival. So this objective is achieved by formulating a rational approach that includes preconceptional evaluation and counseling, early antenatal care, frequent antenatal care visit, timely delivery with intensive intrapartum monitoring, and the postpartum managements are very important strategies in order to achieve the objective that we mentioned above. So let us start evaluations and classifications. So a woman with chronic hypertension ideally be evaluated and counseled before pregnancy. And if this is not possible, they should be evaluated early in pregnancy. So the aim of this preconceptional and early pregnancy evaluation is to assess the severity of hypertension, the duration of hypertension, and the treatment given. So a woman with chronic hypertension taking antihypertensive medications, let us say the blood pressure is not well controlled. So during this preconceptional visit, we need to adjust antihypertensive medications to achieve a target blood pressure to be pregnant. The target blood pressure for pregnancy to occur is like systolic blood pressure 120 to 159 millimeters of mercury, or diastolic blood pressure 80 to 109 millimeters of mercury. During this preconceptional care or early in pregnancy, there is also a need to change those antihypertensive medications who are contraindicated in pregnancy, like ACE inhibitors, angiotensin receptor blockers should be changed. The other importance of this evaluation is assessment of the cause of secondary hypertension should be made, and the third importance is evaluation for end organ damage, especially a woman with long-standing chronic hypertension, particularly those having history of poor blood pressure control, should be evaluated for end organ damage like left ventricular hypertrophy, retinopathy, and renal failure. So we need to do ECG, and if ECG is abnormal, we need to do echocardiography, renal function test, creatinine and should be determined, ophthalmologic evaluation, fundoscopy should be done during this time. The other importance is we need to assess the previous obstetrics history in detail. So this evaluation should be performed by history, laboratory evaluation, as well as imaging studies. In the history, we need to ask up the details of the duration of hypertension, the medications used, the control, as well as the presence of his diagnosis of diabetes, renal disease, the presence of cerebrovascular accident, and others. And the detailed obstetrics history, like the duration of pregnancy, the presence of placental abruption, the presence of the weight of the previous neonate, whether there is IUGR or not, if there is intrauterine fetal death, and others. Laboratory evaluation and imaging studies are also very important. It should be obtained to assess a baseline for future assessment, as well as to evaluate for target organ damage, as we have seen. There is also selective laboratory tests can be performed based on the history suggestive of the cause of secondary hypertension. For all patients, this investigation should be done. For all women with chronic hypertension during pregnancy, we need to evaluate the 24-hour urine protein, serum electrolyte. This is very important, especially if primary hyperaldosteronism is considered as a cause of secondary hypertension. They may cause hypokalemia. The screening for diabetes is very important. Based on this evaluation, the woman should be classified as low risk and high risk, and they should be managed accordingly. So the low risk chronic hypertension, a woman with low risk chronic hypertension generally have the pregnancy outcomes similar to that of the general obstetrics population. In this woman, if we find in the early perinatal or at the early pregnancy, there is a need to discontinuation of antihypertensive therapy. Studies found that administration of antihypertensive therapy in this woman, it doesn't improve the overall pregnancy outcome. It doesn't decrease the risk of superimposed preeclampsia. It doesn't reduce the risk of placental abruption, preterm deliveries. Rather, only it decrease the exacerbation of hypertension. At the initial and subsequent perinatal visit, the woman should be counseled about the nutritional requirement, weight gain, and sodium, salt restrictions. It should be less than 2.4 grams per day, and the cessation of alcohol and the smoking is very important, because if the woman took alcohol and the smoking, it exacerbates the hypertension. The woman should also be closely followed for the sign of preeclampsia and fetal growth restriction. Fetal surveillance ultrasound should be done at 16 to 20 weeks of gestation to assess gestational age and to see the gross anatomy, as well as it should be repeated at 30 to 32 weeks of gestation. Then the weight should be monitored every 3 to 4 weeks, and the biophysical profile or non-stress test should be followed starting from 2 weeks of gestation, then every week. And the low dose aspirin, 81 milligram per day, starting from 12 to 28 weeks of gestations up to delivery should be continued. Hospitalization with severe hypertension with the development of fetal growth restriction warrants hospitalization and immediate evaluation of the fetal condition. In the absence of the complications like preeclampsia, severe hypertension, maternal complication, the pregnancy can be continued up to 14 weeks of gestation. Some say 38 to 39 weeks termination should be attempted. So the preferred mode of termination is induction of labor. Cesarean section is reserved for the other obstetrics indication. High risk chronic hypertension. Pregnancies with high risk chronic hypertension have an increased risk of adverse maternal and fetal complications. The likelihood and the impact of this complication depends on the etiology of hypertension, as well as the presence or absence of end organ damage. Like a woman with significant renal insufficiency, creatinine greater than 1.4, a woman with diabetes with vascular involvement, severe collagen vascular disease, cardiomyopathy, or coarctation of the aorta should be counseled before conception about the adverse effect of the pregnancy on their condition, because pregnancy may exacerbate their condition, resulting in congestive heart failure, acute renal failure, resulting needing dialysis or even death, so that they should thoroughly be counseled. Even the perinatal loss and the neonatal complications were markedly increased if the pregnancy occurred in the presence of these conditions. So a woman with high-risk chronic hypertension should be managed in a tertiary care setup where there is a multidisciplinary team involvement, and the place for maternal and fetal ICU is available. I mean neonatal ICU. Hospitalization of the woman with high risk uncontrolled severe hypertension is very important for adjustment of the medications as well as the assessment of cardiovascular and renal status. So the other important thing in a woman with high risk chronic hypertension is antihypertensive therapy. We do have indication for administration of antihypertensive therapy. In the absence of target organ damage, a woman with high risk chronic hypertension, antihypertensives are recommended if there is a severe range blood pressure, systolic blood pressure greater than 160 or diastolic blood pressure greater than 110 millimeter of mercury. But administration of antihypertensive in this case is very important to reduce the maternal complications like cerebrovascular accident, congestive heart failure, retinopathy, and renal failure. And also it contributes for prolongation of pregnancy and improve the perinatal outcomes. But a woman having target organ damage, so there is a short-term benefit of administration of antihypertensive medications when the blood pressure is greater than 140 systolic or diastolic greater than 90 millimeter of mercury. For acute control, similar to that of a woman with preeclampsia, we can use hydralazine or labetalol or short-acting nifedipine. For maintenance dose, it says that studies found that the labetalol and nifedipines are said to be the first line. Methyl-dopa and hydrochlorothiazides were considered at the second line. ACE inhibitors and angiotensin II receptors antagonists should be discontinued during pregnancy because it increased the risk of oligohydramnios, fetal and neonatal renal failure. The use of Lasix in pregnancy is said to be controversial because if the Lasix is administered starting from early in pregnancy, it reduces the plasma volume expansion than the normal pregnancy. So in a woman with chronic hypertension without superimposition and the suspected fetal growth restriction, this decrement of plasma volume expansion have no significant effect. So some says you can use Lasix as a single agent or in combination with the other antihypertensive. But with the development of superimposition and the suspected fetal growth restriction, it should be immediately discontinued. So these antihypertensive medications have no effect on the rate of superimposed preeclampsia as well as placental abruption. Early and frequent perinatal visit is key. The woman should be counseled like the nutritional requirement, sodium intake and the cessation of alcohol and smoking, similar to that of the previous one. Close observation for signs and symptoms of preeclampsia is very important. Serial laboratory evaluations like target organ damage should be evaluated every trimester at least. The others, if there is a suspicion of preeclampsia, the laboratory based on history, we can request the different laboratories. Fetal evaluations include ultrasound at 16 to 20 weeks, repeated as 30 to 32 weeks. Then the fetal growth should be monitored every 3 weeks. Biophysical profile or null stress test starting from 28 to 32 weeks of gestation should be repeated every week. The other is the low dose aspirin, still recommended. The time of delivery for high-risk chronic hypertension is said to be 36 to 37 weeks of gestation after documenting fetal lung maturity. But if there is a superimposed preeclampsia without severe features, the pregnancy can be continued up to 37 weeks of gestation. Superimposed preeclampsia with severe features diagnosed at 32 weeks of gestation, it is an indication for termination of pregnancy. But if it is diagnosed before 34 weeks, if there is no pulmonary edema, if there is no DIC, if there is no suspicion of placental abruption, if there is no eclampsia, if the fetal testing is reassuring, we may have an expectant management up to 34 weeks. But in the presence of the above mentioned conditions, it is an indication for immediate delivery regardless of the gestational age. So induction of labor is preferred. In the intrapartum, the input-output should be closely monitored and the need for antihypertensive should be considered. Magnesium sulfate should be for a woman with preeclampsia, superimposed preeclampsia with severe features. So those chronic hypertension doesn't require magnesium sulfate intrapartum because of the risk of seizure is low. Lastly, postpartum management. A woman with high-risk chronic hypertension have an increased risk of postpartum complications like pulmonary edema, encephalopathy, renal failures. This risk is very high in those having target organ involvement, superimposed preeclampsia, and placental abruption. So the BP should be closely monitored. The choice of antihypertensives like the the labetalol, nifedipines, and methyl-dopa are safe, even though their concentrations in the breast milk is low. There is no effect on the neonate, they can be administered. But the ACE inhibitors and angiotensin receptors, they cross the breast milk, they have a neonatal effect on the kidney, so they should be discontinued. The diuretics, even their concentration of diuretics in breast milk is very low, but they induced a decreased milk production, so that they are not good. Thank you for watching. If you are new for this channel, don't forget to subscribe the channel to have more videos.